Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality. Hi, everybody, and welcome back to another episode of Hot for Your Health, where I interview some of the most fascinating minds available today. And today is no exception. I feel like I have known Dr. Killen for quite a while, but it's on the internet. So today is the actual first time that we're speaking in person. And, I could say she is a boarded emergency department doctor, which she is. I could say she is a longevity expert, which she is. I could say that she speaks all over the world on a variety of topics, including sexuality, which she does. But you're also an entrepreneur and a cold plunger. So you do all kinds of things, and it's just fascinating. So I'm so glad you're on Hot for Your Health today.
Well, thank you so much for having me. I'm excited. Yeah, it's so good to meet you in person. I love all the things you're doing with the joints and the bones and the hormones and all the things.
All the things. That's right. Well, and I'm really interested in so much of your life, but in particular your longevity life, because my work as an academic surgeon was always researching aging and longevity of the musculoskeletal system. And thank God people are listening today. So I think that's really why both of our worlds are kind of exploding. But I wanted to get your take on something I heard on, I don't even remember whose podcast it was on. I was just listening and somebody made the comment, well, when men talk about living a long time, they are treated to the word longevity. We're talking about their longevity. But when we're talking about women living a long time, it's always framed as anti-aging. And I'm a little not in that camp. I'm a little offended by that statement. And so as a longevity guru, we're going to get to this, starting a new enterprise, just respond to that. I mean, why do you think that is? And where are we now in terms of not describing women's lives like that?
Well, we have a long way to go, I think. The longevity field is fascinating. It's like all the rest of medicine, I think, in that so much of the research has been done in males, humans, male mice, male monkeys, male, worms, probably, like everything is male, really until the last 10 or 15 years. And so much of what we know about from men, and we just extrapolate and say that that's probably true for women. And I think that there's this idea, a lot of women used to use the term, I don't know if we still do, some do, that term anti-aging. And, it has a lot of different meanings, right? Like, I think it can be taken pretty negatively. Like, we're never going to age. We're always going to look 25 and we're going to be, we're going to use a lot of procedures and try to look fake. And I think none of us, currently none of us are anti-aging. None of us can stop aging. But I like the idea of it. But I do like longevity better, although I don't even know if there's what is the best term? Is it just prevention? Is it being proactive? Is it taking your health seriously? I feel like there's a lot of ways to describe the idea that we actually have more control over our health than we thought we did.
I think that's a really great point, because is the question, are we really trying to live 725 years or, ancient Old Testament guy Methuselah lived that? Are we really trying that? Or are we trying to maximize our potential for living longer and in doing so living healthier? So I think, even you're right, even defining what it means, longevity right now is the key word, because so much of it is not, and this is so important, and you talk about this all the time, so much of it is not the really unusual biohacking that you can go down a rabbit hole, right? So much of it is exactly what you said, prevention. And is there a way to sort out what you think is most important?
Yeah, I think, the longevity field is interesting. I've had these discussions at various longevity events. There certainly are people who are working very hard in laboratories all over the world to try to, stop aging or even reverse aging. Yeah, there's cellular reprogramming and there's all kinds of, gene editing and all these things that are being looked at. And I think at some point, probably we will be able to, first slow or stop aging, maybe not stop, but slow it. And then maybe eventually turn back the clock. But we're years away from that. And I think that right now, what we need to focus on is what can we do right now today? Like my focus when I talk to groups of people is not like, what are all the technologies coming out in 10 years or 20 years? It's, hey guys, we only have, less than 10% of the women who are in menopause take hormone therapy. And that's one of the best things that we know of that we can do outside of lifestyle to slow down all the sort of things that come with aging. So why don't we work on that first?
Right. Well, and that, that's such an issue today versus technology, right? Because do you think people skip the easy stuff? Do you think they immediately, their health's not optimized, their health is fine, I feel fine, but it's not optimized? Do you think they go from that to, can I exchange my plasma? Can I take some pill? Do you think they just skip all the good stuff, the easy stuff?
I think that they skip the good stuff, but they do so because it's not easy. They skip it because it's hard. They skip, like it requires work. Like you got to watch what you're eating. You got to get outside. You got to move. You got to lift heavy. Like these are the things that require us to give of our energy and our time. And it's much easier to take a pill or to get a young blood transfusion. Right. That's actually much easier.
Yeah, exactly. Well, it's interesting. I've we don't have to name him, but there's a interesting guy trying all the things. And in my lab many, many years ago, we were thinking about the experiments that were being done, sewing a young mouse to an old mouse. Mm-hmm. And it's changing all the proteins in the blood and what it did. And it's interesting that humans are now trying it. And yeah. I don't know if it's working, but it looks like it's interesting. So you're right, Amy, Dr. Amy. I'm going to call you Amy for this.
You can call me Amy. Yes, please.
Yeah, please. And you'll call me Vonda. But you're right. The easy things aren't easy. The easy thing would be a pill. Yeah. The hard thing is actually investing every day in our health. And when we think about, describing longevity and everything that goes into aging, originally there were 6 pillars and then there were 9 and now there are 12. But I tend to boil them down. I think there are 3 or 4 really critical ones. Do you think, what is more critical? Is it the epigenetic pillar? Is it the cellular reprogramming? Is it the mitochondrial health that is the pillar of the pillars? Which one do you think is most actionable?
I think that they obviously all work together and they all feed each other. But I think some of the things that are the most actionable are probably the inflammation, reducing inflammation system-wide. And I think that mitochondrial dysfunction is part of that also, but keeping your mitochondrial, fueled up is a big part of it. I do a lot of work with stem cells and things like that, and that I think is important, but I think that those are more kind of downstream. Like if you can keep your mitochondria happy, if you can, reduce inflammation, that's going to do a lot towards reducing some of those other hallmarks of aging and the senescent cells and the stem cells, all that kind of stuff.
And so when a patient comes to your private clinic, are those the 2 pillars you start with them? You're looking at their inflammation and their metabolic dysfunction likely, right?
Yeah, I think that, everyone's different. Obviously, we like to do a full history and intake and, lifestyle as well as medical history. And then like to do a full lab assessment that looks really at just kind of casts a wide net and, certainly looking at inflammation and inflammatory markers, but also looking at risk factors for heart disease and dementia and cancer and some of these things that are the things that are most likely to kill people. And then also looking at hormones, what the things that we can change. So certainly checking with these things that we know that we can actually affect. And then from there, seeing what is going on. And usually most people have, a few things happening that are driving everything else. Like, so maybe it's an inflammatory process that's going on, but that's causing them to also have problems with their digestion or with their joint pain or that, like a lot of times there's a bunch of symptoms, but they're kind of coming from one or two underlying real problems.
Right. And you see trends with what they appear with first based on whether there are men or women or XX or XY and age, or is it truly so precision that you can't predict by demographic?
I think that my population, I see mostly people that are, 30, 35 plus. So I see a lot of women, obviously, in perimenopause and menopause. And as you know, that could be 30 different symptoms. It could present in all different ways. But there are kind of these sort of avatars, like there are people who, there's multiple different people presenting with the same kinds of symptoms. And so even though everyone is very individualized, I think that we can look at, kind of groups of information and say, okay, this person probably has this thing. And that's one of the things that we're trying to do. I'm starting this longevity clinic, and we're going to be a franchise, and on the chief medical officer. But the difficult thing is, how do we scale, a medicine that is so complicated? Like, we have access to so many things that we want to be able to use in a personalized way, but how do we scale that so we can get it to more people? So that's one of the things we're trying to figure out.
Well, I'm glad you brought that up, because I had seen the announcement when it was announced that you were going to lead this venture, establishing and really trying to democratize and don't let me put words in your mouth, but the democratize access to this philosophy of care, which is focused on prevention, therefore longevity. But it isn't easy to democratize, is it? Because it takes a long time. I mean, you can't do it in 15 minutes.
Yes, exactly.
Which is what the typical physician is. Right. And so it demands cash services or some, how do we, gosh, sometimes I think about, because sometimes I feel like I'm in an insular bubble. People who come to me want to feel great, and because they're seeking that out, like you, right? But then we frame that in the fact that 70% of the people in this country don't move, or that, whatever the statistic of diabetes and obesity. How will we ever democratize this approach?
I think it's a good question. And I think, I remember back when I was in the ER, patients would come in all the time with complaints that could have been fixed with lifestyle. But they didn't want to hear that. Like, and this is not everyone, this is some people, but, they would have, you've seen this, they would have joint pain because they were, 100 pounds overweight. And you would tell them, I think if you lost some weight, like, I can help you, and here's how you do it. And they would be like, I just need you to give me a pill. So I do think that there is something that we need to shift, in mindset, in the population at large, that says, hey, a doctor is not going to make you healthy. Like, a doctor, they're not going to be the people who save you. And yes, we have great medicines. I'm very much, I'm a traditional doctor. I love medicines. I love all the things we could do, but those medicines are not going to be what actually makes you healthy. And I think that mindset needs to be shifted before we can actually make this accessible to all the people.
Well, what you just said brought to mind that maybe we have created this dependency. When I was in my first career, I've been at this a very long time. I was a nurse, and it was still the times when people stopped. The people had just stopped standing up when doctors walked in the room. Just stopped. And it's been a transition in my career of yes, doctor. Now my patients are smart. They're educated. They know what but maybe we created this, Amy, that people think we're responsible for every part of their health, that it's not their responsibility at all.
I definitely think that we did. I think that there's a lot of the blame lays on us. And I think that as a medical establishment, we didn't mean to, but like, we've kind of let it get to this point where if you're in traditional medicine, you have 5 minutes with the patient, and that's all that you have. And, it's kind of just gotten worse and worse and worse. But, I've been out of traditional medicine for 10 years, and that was a big part of it. Like, yes, on the one hand, I hate that I have to charge people to see me. But on the other hand, I can spend an hour with you, and then I can spend 30 more minutes afterwards researching exactly what it is that you have and what's the best, peptide or supplement or medication or lifestyle change or whatever it is that would help you. And that's just not, that flexibility is not something that we see in traditional medicine. And I think that that's one of the big problems.
Absolutely. There's just you work inside a box and there's no way to do actually what you do. And I do part of the time outside. So you've got this patient coming in. You said that probably, and I agree with this, probably the foundational issue for most things we see is inflammation and mitochondrial dysfunction. So you've got this person come in, and I want to explore a little bit. In addition to all the things people could probably name off from watching us, you have to move, you need to stop eating sugar, you need to lift some weights. If we're trying to really go after those two pillars of aging, what are some of the interesting things you see coming up? You named peptides.
Yeah.
That's complex. What's interesting coming up for just those two pillars, so we stay a little focused?
Well, I think that for inflammation, this is not necessarily new, but I think that we're going to see more and more use of the GLP-1s, the GLPs, GIPs, glucagon. Yeah, there's multiple different categories now, but these medications that like Ozempic, but I think that people have been talking about these for years, but we know that they are excellent at reducing inflammation. And now, there's starting to be studies. Yes, maybe it can decrease neuroinflammation. Maybe it can decrease joint inflammation. It can, decrease inflammation because with polycystic, it can affect inflammation system-wide. And so I think the next thing that we'll see is how do we use these medications in patients who don't need weight loss necessarily?
Yes.
Like maybe they're healthy weight, maybe they're a little overweight, but they're not obese, they're not diabetic, and yet they still have a problem that's associated with inflammation. And, can we adjust the dosing? Can we adjust the timing? Maybe it's every couple of weeks or once a month, or maybe the dosing has come down a lot. But I think that that's one of the big things that it's already kind of happening in like the longevity space, but it hasn't kind of gone out, into the traditional medicine yet. And then there are a number of great peptides, which is a little controversial. These are not, and again, I'm not trying to be like, but they're not FDA approved, but they're also not, the ones that are being used currently are also not illegal. Like the pharmacies are making the ones that they can. They're not making the ones that are illegal to make. So, but there are some great peptides that can help with inflammation. They can help with mitochondrial function, kind of energizing the cell. And these, peptides are just short proteins, and they're already in your body. So we're not taking foreign substances and putting them in you. Essentially, it's taking something that you already make, these, a few amino acids long, and using it in a new way. And I think that we'll continue to see more and more, hopefully good studies and research and things come out about how do we use these the best way.
And so when you put someone hypothetically on either one of these things, short peptides or GLP-1s, what are we measuring to know that the patient is getting better? Is it purely looking at their A1C or their GSP or their inflammatory markers, or is it how they feel? They're like, oh my God, I don't feel hot and red. And how do we know we're successful?
Yeah, I think it's both. I think it's the subjective symptoms. Oh, my arthritis is not hurting as much anymore. My knee I can walk a few blocks versus, before I couldn't. Like, I think it's those symptoms. But then, of course, you can also measure in the various inflammatory, there's, the CRP is easy to measure and a lot of people do that. But there are tons of other inflammatory markers that you can, the different interleukins, that you can go deep on this. But really, I think you don't have to go that deep with most patients because they'll tell you. Like, if it's not working, they'll say it's not working. Or maybe I feel a little something. If it's working, they will come in and they will tell you, oh my gosh, let me tell you my story. This is what happened when I took this.
Well, and you know what? I agree with that because even in standard medical practice, in orthopedics, we say we don't treat your X-ray. We treat you. And when it comes to arthritis, now if a bone is on opposite ends of the world, of course we treat the X-ray, but we treat the person and how they're feeling. So I tend to totally agree with that. How do you address the medical community? Listen, I was in an ivory tower for 20 years. I get it. I am a scientist with both bench and clinical. How do we, because now I try things that have not gone through the entire RO1 research system. How do we talk to the public about, okay, it's not FDA approved. We have some moderate amounts of data because research is expensive. You're not my guinea pig. Here's why. What is that conversation like for you? Because there's a big battle going on social media right now between if it's not FDA, it's not good versus, there is some ancient wisdom that we should pay attention to in both the Chinese culture and the Indian cultures. What is your overall thing? I'm going to shut up about this.
No, you're exactly right. And I think there's the other people too who are so against traditional medicine. They're so against, big pharma that they won't take medications. Like they would rather take, red yeast rice, which is a supplement, than just take a statin, which is just the more pure form of that same ingredient. Like there's also that. I think there's people on both sides who are very, very, they're very stuck in their ways. And I tend to be, I kind of live in the middle there. And I feel like we do want to be open-minded, but whenever I talk to patients and if I have something that I want to recommend or just talk to them about that is not, standard of care, or maybe it's a regenerative therapy, maybe it's peptides, maybe it's even hormones used a different way. I always, I'm very open, and I think that's part of it. Saying here's what we know as far as evidence goes. Like it's in this animal model or this small population of humans, and here's what the side effects potentially are. I think that's a big part of the conversation. Like what could happen? Like what's the bad thing that could happen? And obviously, if the bad is pretty bad, then we just don't do it. And then, what are the reasons why we might try it, and what should you expect? And I think that, most people are very smart. Like you never want to guarantee someone that you're going to fix them, that you're going to cure them, that you're going, that their Alzheimer's is going to go away because you gave them this thing. Like you never make those guarantees. And for me, I tend to lean even more towards like, I don't know if this is going to help or not. Like this may or may not help. Like I really think that not even planting in their head the idea that it's going to work is important. However, we also know the importance of the placebo effect, and that's a whole other thing, right? Like your brain is so powerful that if you think something is going to work, there's a good chance it's going to work. And so how do we use that without being unethical? That's a whole other conversation.
It is. Well, and I think there are room for both, because if we wait around for the 20 years it takes for every molecule to get through the 3 levels of testing, we will have nothing new to offer people. So, but you know what? I loved what you said. So if you're listening, people, what Dr. Killen has said is that you need to have an honest conversation with your doctor. They need to be honest with you about the expectations, why they're suggesting it, the risk and benefits, what can you expect? And if they promise you it will cure you, maybe you have to actually question that, because it doesn't seem like a totally honest yes. Yeah. And the more educated, the better, right? The more educated the patient is, the better.
Yeah, absolutely. I think that I know some doctors, they probably hate my Instagram because I'm always like, go ask your doctor about this. But I do think that there's so much information. No, doctors can't learn everything. Like we do our best, but you can't know everything. So having patients bring, interesting questions to you or interesting papers to you, like to me, a sign of a good doctor is the one who says, thank you so much for bringing that to my attention. I would love to learn more about that. Let me come back to you later about that. But you never want to stop learning as a physician or a patient, because there's no good resolution if you stop learning.
Absolutely. And what people don't realize is that what we get when we're done with our fellowships, I've been out of fellowship since 2005. I mean, it's obsolete. As doctors, we are constantly learning, right? And so I think people don't realize that. So that attitude is just great. Bring us what you've learned. And if we don't know it, we can vet it for you, given our knowledge of how to vet research, et cetera.
Yeah, it's hard because even guidelines, if you look at like the guidelines from different medical organizations, those are often 5 or 10 years out of date. And so, sometimes you'll have whatever, maybe it's menopause guidelines or urological, whatever it is, but you'll have these guidelines, which are, they're kind of general recommendations that doctors can use. But I would argue that a lot of times those are also out of date, that we have more information, that there's, that even the guidelines are not perfect. And so it's difficult to weigh, like, how far out do I go? Like, I don't want to be jumping off a cliff by myself, but I also do want to push the envelope a little bit, and I want to learn new things that I can offer to my patients.
Yes, absolutely. So I want to, before we get too far down the road, I want to return to the subject of these new longevity clinics that you're the medical director of. Tell us more about that, where they're going to be, what the patient experience will be like.
So thank you. It's called Humanaut Health, like astronaut, but with humans. Humanaut Health is the brand, and we're opening our first clinic in Austin in early September, and then we'll have 2 more in Texas within a few months after that. And then we'll kind of wait a year, kind of get all the kinks worked out, kind of make sure we can do it. And then the plan after that is, really to go nationwide, within 3 years. So we have kind of a roadmap to that. So I'm the chief medical officer, and my job is to create, along with our medical advisors and team, but to create the clinical protocols for, how do we treat these various different things? What do we offer? What do we not? Like, where are we sourcing our compounded medications if we're using those, or medications? And so it's a lot of logistics, but our goal is to give people a place that are really interested in being proactive, and they're interested in this, health optimization, this longevity field. So we're not a primary care doctor. We're not, taking care of your cold and your broken ankle. But if you want to kind of go beyond that, if you want to really reduce your risk for whatever risk factors, if you want to get advanced diagnostic testing that you can't get through your primary care doctor, then we'll have a place that you can do those things.
So it's almost like the paradigm you're shifting is, you can have your disease doc, you can have the ED for emergencies, your disease care doctor for your diseases, and then you have your Humanaut or life longevity doc. You have your life doctor.
Yeah, that's exactly it. And our hope is to work with, maybe not directly, but to work with the traditional medical system. So obviously we're not trying to take those patients away, but maybe you have someone that's following you for your heart disease, but they're only offering you 1 or 2 things. Well, we know that there are a lot of things that can be done with lifestyle, with supplements, with medications off label, maybe the GLP-1s, where we can resolve or turn back even, when you have clot in your, it's like soft plaque in your arteries, like we can turn that back, we can get rid of it. But it just takes a lot of things working together. It takes a lot of knowledge. And it also takes, health coaches and people reaching out to you and making sure that they're helping you. So we want to work with the cardiologists or with the OBGYNs or, the people who are managing the sick parts of you.
Yeah. So in a very collaborative manner.
Yeah, that's our hope. When who knows how we'll be received. That's one of those things we don't want to step on toes, but we do want to change what kind of access people have to this kind of healthcare.
So when people are out looking for a longevity doctor, somebody like this, what are they going to be Googling? Because they could Google lifestyle medicine. They could Google functional. They could Google integrative. They can Google now longevity doctor. And what are they looking for? Because there's no fellowship in this right now.
No, it's kind of like the same thing with hormone doctors, right? Like what are you Googling? And the problem is you may have one functional medicine doctor who is doing things completely the opposite way as someone else, or you may have one OBGYN that, there really is, it's very difficult. I think you could start with longevity medicine or hormone optimization, or some of these kind of catchphrases, but ultimately I think that you just have to go and meet the doctor, sit down, have an interview, and obviously that's time consuming and it's kind of annoying, but I don't know how else to really understand what they believe in and how they can help you without that face-to-face time.
But I do think that the baseline is that, and this is my bias, but you can please give me your opinion. I think they have to be some kind of allopath or osteopath, some formal medical. You have to have passed some boards.
Yeah.
You can't say that I think I love this, so I'm Dr. Longevity.
Yeah, I definitely think that you want to have a medical doctor or a DO. Although I have naturopathic doctor friends who are excellent, and they have they have a different philosophy, but they're excellent doctors. I think where you really get in trouble is when you have, maybe chiropractors who are talking to you about your hormones and trying to I feel like these doctors all have, and these specialists all have their place, and they can all be helpful, for getting you where you need to be. But we all kind of have different roles. And you just want to make sure that if you're having someone who's actually, ordering diagnostics that are pretty complicated or interpreting them or giving you actual medications, that they know what they're doing and they didn't just take a weekend course.
Exactly right. So when someone would come into Humanot or any longevity clinician, doctor, is this a lifetime relationship, or is it, okay, we're going to work with you for 3 months or whatever the time period is, and then you're launched? Or give me your thoughts on it.
Obviously, we would love to have you for a lifetime. But I think, we'll have different kind of levels of membership. Like some people, we're there kind of just to help guide you, and you're on your own path. Like you don't necessarily need a lot of help along the way, but we're going to help you with the labs and maybe some medication supplements, and we'll see you every 3 months. The higher tiers, we're going to be more hands-on in terms of health coaches or meeting more frequently or doing more, more deep dives in some of the labs. So we'll have different tiers of membership depending on what you want and what you want to pay. And then, it'll depend on what you're doing. But I think at least 6 months would be a minimum. You're not going to make a lot of big changes, before 6 months usually. And if we're trying to work on lifestyle, especially, that takes longer. Hormones takes longer. As these things, you don't just give a single pill and send them on their way and they're great. There's an adjustment, and there's up and downs, and there's, figuring out doses and all of that. So, and then I think, with longevity medicine, there's always more you can do, right? Like even if you're perfect, your diet is perfect and your exercise, everything's perfect. There's so many of these potential off-label tools out there, whether it's medications, GLP-1s, rapamycin, and carbos, the SGLT2s. There's a whole class of medications now that we think, could be useful in the right people. So there's always more we can talk about doing, whether we do them or not with you.
And I love that what you've just described is a very stepwise approach. You come in, you address the more familiar things, and then if you keep going, you reach for the obscurity in the biohacking. Lots of people want to just jump to that, though, in my experience.
Yeah.
Because it's easy. You have pointed out, because that's easier. That
it is.
That
it's easier.
Plugging it out. Did you ever jumping in this cold tub that you do so frequently? I can't fathom. I hate my belly being cold. You must just be so brave. But you know what I've added? I mean, this is so off topic. I've layered on the habit of getting in the sauna 20 minutes a few times a week. It adds more time, but we'll see what these heat shock proteins are going to.
Yeah.
So for the hot versus the.
No, there's lots of great. Sauna has a lot more evidence than cold plunges, obviously. Cold plunges, I think they feel good afterwards. I like the adrenaline rush that I get, but there's not a lot of data really that they're all that good. It's more of a I think it's a kind of a trendy thing, and I feel good in them, but some people hate them. And so I think, but saunas, there's great evidence for saunas, cardiovascular disease, dementia prevention, all kinds of things, inflammation, all of that.
And that's something I like about you on social media is that you cite the data, you lay it out, you interpret it, you draw great diagrams, or somebody does great pictures. But I just appreciate that about the way you educate people, because sometimes you do talk about things that are out of the box. Many times you talk about things that are totally in the box and explain them in a way. So I just think it's great.
Oh, thank you.
Yeah. So, well, I really appreciate you laying out Humanot, your approach to longevity. I can't wait to see how it grows. And also, thank you for connecting me with the longevity doctors groups. I'd love to meet people, because, we're all out here doing it on our own right now. So it's great to share ideas. So
yeah, there's an event in, I think it's October in New York. So if you're able, you should come. It'd be fun to meet you in person and introduce you to some of the other people. You probably know some of them already, but introduce to you some of the friends in that space.
I would love that. Well, Dr. Amy Killen, thank you for being on Hot for Your Health today, and I'll talk to you really soon.
Thank you so much. Bye-bye.
I'm Dr. Vonda Wright. See you next week.